Hello, my name is Clare Garnsey. I'm one of the breast surgeons at Bolton Hospital, and I'm also the clinical lead for breast cancer at the Greater Manchester Cancer Alliance. I'm going to be talking to you today about breast pain, Mastalgia. So a significant proportion of your workload, and certainly a large proportion of our workload, is managing patients with breast pain. Audits across Greater Manchester show that about 20% of all breast referrals to secondary care are for breast pain. Perhaps the most important message is that breast pain is common, and without other breast symptoms and after excluding non-breast causes, it should be considered normal. When a patient does arrive in your practice, though, with breast pain, you do need to ensure there is no other cause for concern. So in your history, you want to rule out other causes for chest pain. And the majority of patients who present with breast pain actually have underlying chest wall pain, costochondritis. And as you know, the treatment for costochondritis is simple analgesia, non-steroidal anti-inflammatory drugs, and in those very severe persistent cases, perhaps corticosteroids. You'll want to rule out cardiac and pleuritic causes, and it's always worth checking that your patient isn't pregnant because, of course, that is very much associated with breast discomfort. In your history and through your examination, you need to exclude red flag symptoms of breast pain. So that's the breast or axillary lump and skin changes such as tethering, puckering, redness, and peau d'orange. If there is new nipple inversion, that is a concern, as is pathological nipple discharge. So that's unilateral, uniductal, bloody discharge. If there are no red flag symptoms, then the national guidelines just say that you need to reassure the patient. We need to be telling women that breast pain is unfortunately normal for women, and it happens to up to 70% of women at some point during their lifetime. It's important that we stress that breast pain is not related to breast cancer. And there is some sensible advice about breast pain on the NHS website. The patient will, of course, though, want to know what we're going to do about their pain. Small randomized controlled trials and cohort studies have shown that topical NSAIDs are effective and are more effective than oral NSAIDs with fewer side effects. So we certainly always recommend a topical ibuprofen gel to be put onto the affected breast. When women attend our clinic with breast pain, we find that the vast majority have a poorly fitted bra. We would advise women to attend a professional bra fitter, and usually their bra is not only the wrong size, but it is the wrong shape. So it needs to have a wide strap over the shoulder, a wide band round the back, and a well-fitted cup size. And also women with breast pain may find that a soft supportive bra is really helpful at night. We don't recommend the use of evening primrose oil, reducing caffeine, or routinely changing the patient's oral contraceptive pill, as there's no strong evidence that these things help. You may have heard of hormone modulating medications and wonder whether these are medications that we might prescribe for breast pain in secondary care. Danazol, tamoxifen, Zoladex, and dopamine agonists. Now, although a small number of small trials and studies have shown that these medications do result in improvement of breast pain, they are not licensed for treatment of Mastalgia apart from Danazol. And perhaps most importantly, the side effect profile of these medications is really significant. So Danazol can give women menstrual disruption, acne, unwanted hair growth, vaginal dryness, and voice change. As you know, tamoxifen can give significant menopausal type symptoms and an increased risk of thromboembolic events. And dopamine agonists can produce nausea and vomiting, constipation, headaches, and dizziness. In the 10 years that I've worked as a breast consultant, I've never prescribed any of these medications for breast pain, and I don't know any colleagues who do that routinely. What we do know is alternative therapies seem to produce a similar benefit as these hormone modulating medications, suggesting that there might be a placebo effect. I don't promote these alternative therapies in clinic, but certainly if a woman is interested in them, I don't dissuade her either. So with breast pain, when should you refer to secondary care? I think the short answer is, in general, these patients should be able to be managed in primary care. Of course, you'll want to exclude musculoskeletal, cardiac and respiratory causes. But if you're thinking you need to refer into secondary care, please could you give the patients the conservative advice first of trying a topical non-steroidal gel and ensuring they're wearing a well-fitted bra and reassure them that breast pain isn't related to breast cancer. If then, after 6 to 8 weeks of trying these simple treatments, they're still struggling with breast pain and unable to accept reassurance from a primary care practitioner, we will of course see these patients in secondary care. All breast patients should be referred using the standardised referral form, and breast pain patients should be referred on a non-urgent 2-week wait pathway. I'd just like to point out the pathway for management of mastalgia that has been developed. It's on the right-hand side of the screen. This can be found at the GM Cancer website, but it's also available on your electronic system. If you type in breast pain or mastalgia, this should pop up on your computers when you're seeing the patient. And it's just a recap of what we're talking about in the presentation today. If a patient with breast pain is referred into primary care and they're under 40, we don't tend to do a lot more than that which you do in primary care. So we take a history and we perform an examination, but we don't generally perform any imaging. In patients over 40, they do tend to get a mammogram. That is historically what we've done as patients over 40 come into the triple assessment clinic. There is not strong evidence for this, which we'll come on to very shortly. During COVID, there's been a national trend towards reducing unnecessary triple assessment appointments and the associated patient anxiety that goes along with that for those patients with breast pain without red flag symptoms. So many secondary care providers in Greater Manchester and Cheshire are now able to manage patients with breast pain over the telephone. So we do a history and then we reassure the patient. If the patient is over 40, we may arrange a mammogram at a separate appointment for them. During COVID, whilst we've been running the telephone clinics, we have been auditing our practice very closely. And this shows that in patients over the age of 40 with breast pain, when a mammogram is performed, less than 0.5% of those mammograms detect a cancer or a pre-cancer. And these cancers were completely incidental. So they weren't at the site of the breast pain. And in 50% of the cases, they were in the contralateral breast, to the breast where the patient was feeling pain. So this suggests that the pickup rate in patients with breast pain is lower than screening the general population of women over the age of 40. If we consider that the screening rate of asymptomatic women in the National Breast Screening Programme is 1%. So this leads us to think that possibly in the near future, we will be admitting mammogram from the mastalgia pathway. So in summary, in patients with breast pain without red flag signs or symptoms of breast cancer, it is safe to offer symptom control advice, so that's topical non-steroidal gel and a well-fitted bra, and to reassure the patient that breast pain is not related to breast cancer. I hope that's been useful, and thank you very much for listening.